We are live, sir.
Sure.
Okay. So good evening, sir, and good evening, everyone. So it's a privilege and honor to be really, sir. In fact, it's a really pleasure and honor to have you here for this particular meeting on this webinar. So a warm welcome from behalf of the Genova entire team and. Sir, especially as you've been, the part of this particular talk on in Encircle Anemia Care in cancer. So team, we have Dr. R.M. Subaya with us. So he'll be giving talk on practical tips in IV and uses. And Dr. R.M. Subaya, sir, he is a consultant clinical hematologist and BMT physician associate with the Kaveri Hospital, Trichy. So, sir, without much ado, I request you to uh, start your session on this particular topic on IV and uses practical tips.
Yeah,
Over to
sure.
you, sir.
So thank you. This is a very important topic for our day-to-day practice. Very simple topic, but it's a very there's a lot of data. So what I'll try to do is I'll just discuss the basics, very which is very important for even for simple general practitioners um, to all specialities. So with the we have enormous data since because iron has been used in parenteral form over last few decades, and it has evolved so much. And then discussing in few minutes is not possible. So we will just try to go through the principles of what do we do in the clinic, especially how do we diagnose diagnose iron deficiency anemia. Then how do we go about it? Who are those candidates who will have to select for IV, just not the oral one? So that is how we'll go about. Okay, the first important thing is we have to understand that anemia, um, that is, anemia can happen due to these reasons. So either it's less production in the bone marrow, the where red cells are less, or it's an increased loss. So the loss can be either in the form of bleeding, which can be again acute or chronic for a long time, or it can be due to hemolysis, that is, the blood cells are lost due to destruction, either intravascularly or extravascularly, and again it can be acquired or inherited. So only these three mechanisms anemia can happen. So either less production or increased loss. Increased loss is via bleeding, where the blood, the red cells, white cells, platelets, and plasma, everything is lost in bleeding. Whereas in hemolysis, only the red cells are destroyed within the bloodstream, either intravascular or it could be sometimes extravascular, as in liver or spleen. So the reduction in oxygen carrying capacity of the blood is anemia, and it can happen in all these three ways. So it's very, the prevalence is very high in our country, and it could be commonly seen in school-going children or elderly or menstruating females and a lot of other individuals. And often there are some consequences in the pediatric age group. We all know well, it retards the growth and recurrent infections can happen. Often in the adults, we don't take care, especially in the elderly, we tend to ignore anemia. So it has got a lot of problems. So there's a higher incidence of cardiovascular disease. It increases chances of heart failure, all with especially with an existing underlying heart disease. It can lead on to increased forgetfulness, so cognitive impairment, and thereby increasing morbidity, mortality, and increased risk of falls and fractures again, which can hamper the activities of daily living, and it can increase the cost also for even doing the activities of daily life. So decreased performance physically, and then quality of life also goes down when the hemoglobin is less. So in adults, we take less than 12 grams in females and less gram 13 grams in males as anemia. In pregnancy, it's less than 11. So one important thing is this could be an early sign of a previously undiagnosed malignancy. So that is important. So we need to evaluate anemia, especially whenever we encounter it, and not to ignore those abnormal values. So so how do we go about it? First thing is, yeah, the value should strike the physical examination. We could see pallor. The patient might look papery pale sometimes, and in the labs might show a low hemoglobin. So whenever we encounter either clinically or in the laboratory, it's important that we'll have to evaluate these patients. So these are the four important principles whenever you handle patients with anemia. There's no alternate for the first one: good history and a proper, thorough physical examination. You have to spend time in the first point. So if we miss history, then for example, patients on antibiotics over the counter sometimes, like for, drugs like linezolid, some can cause anemia. Chloramphenicol, all these can cause either bone marrow suppression or increased peripheral utilization. So it can happen. There are no tests to confirm drug-induced anemia. So it's very important that we go through all the pharmacy bills, proper history. Patients in our country often go to the quacks. They would be given some native treatment, which can cause hemolysis. All these can happen. Examination part, proper general and physical examination, thorough systemic examination is important. Clues can be from simple pallor, icterus, adenopathy, ognomegaly, bone tenderness. All these can give you clues. Previous workup is always important. You'll have to, because the long-standing anemias can be picked up from that, and the chronicity can be ascertained if it's been there for a long time. And the next thing is see all the three lineages together. Three lineages is red cells, white cells, and platelets. Why? Because sometimes anemia may be coexisting with the leukopenia or thrombocytopenia or leukocytosis, thrombocytosis. All the different combinations can give you different differential diagnosis. That's why it's important. And all these three lineages are formed together in the bone marrow. So when one is disturbed, there is a high chance the other lineage might be disturbed. So that's why we see everything together. Why I'm saying this is we see now some follow-ups, especially some cardiology follow-ups or ANC patients, the only hemoglobin will be done. White cells, platelets might be ignored. So, and the machine is going to take the same time to give you those reports also. So, it's always better to see the CBC in entirety rather than just ignore just seeing only hemoglobin or something like that. The third point is the smear examination from the peripheral blood, which is the crucial part of evaluation of anemia, because a lot of differential diagnosis and clues can be obtained from those simple findings on the smear. Hemolysis, malarial parasites, dysplasia, malignancies, rouleau formation, leukoerythroblastic blood picture, teardrop cells, a lot of findings, and each point can give you suggest at least give some differential diagnosis. That's why it's important. And often in our setup, we just send the samples writing as peripheral smear, and the pathologist at the other end may not know what's the patient having exactly. So we'll have to enter on the request form all the findings and what do you suspect in order of priority, the differentials, whatever you think, so that the pathologist will have some idea to look onto the slides, what to see really for. And the last is, in case if a bone marrow material is needed, ensure an adequate bone marrow is aspirated, the biopsy is adequate. A suboptimal material may not give you a proper diagnosis. So example, for myelodysplasia, you need a good bone marrow morphology assessment, and also that's why the particles has to be there. Sample should not be diluted. It should not be clotted. It has to be spread properly on the smear and stained well to see. So similarly, the biopsy also. A suboptimal material may not give you a proper diagnosis. So those are the important principles you'll have to remember whenever you evaluate abnormal CBC or a patient with anemia. So this is well known. CBC parameters: hemoglobin, hematocrit or P spark cell volume, red cell indices, that is mean corpuscular volume, mean corpuscular hemoglobin, mean corpuscular hemoglobin concentration, and red cell distribution width. From the white cell, you have got the differential diagnosis, the differential population of white cells, that is three part and five part. Three part is neutrophils, lymphocytes, and mixed cells. Five part is neutrophils, lymphocytes, eosinophils, basophils, and monocytes. And platelet indices, similar to red cells, you've got red cell volume and red cell platelet volume and platelet distribution width. So hemoglobin 11, 12, 13 in pregnancy, females and males is important. You have to remember. So the upper limit is 15, and anything more than that, you'll have to think about polycythemia. Less than that is anemia. 11, 12, and 13 in pregnancy, female and males. Hematocrit is the red cell, a solid component within that blood, especially when after leaving it some for the vacutainer or the tube for some time, the plasma is at the top, and the red cells, along with the white cells and platelets, do settle down. And the solid component is what we see as PCV, the red, especially when we leave it in the vestibular or Winthrop's tube, and that value helps us in guiding the fluid management. It might be more in patients with burns, pancreatitis, third spacing, or volume loss due to dehydration. So it will help us to in guiding the fluid management, especially in the ICU or patients with dengue fever and all. Red cell indices will give you a clue towards why there is anemia. MCV is for it'll give you some differentials. Microcytic cells, there are some causes, macro, some causes, and normocytics, there are some causes. MCH is for the content of hemoglobin within single red cell. So it's low in iron deficiency. MCV is low in iron deficiency, thalassemia, inflammation, sideroblastic. MCHC is for spherocytes. So whenever it's high, you think about spherocytes are there on the smear, and RDW is helpful in patients with microcytic red cells, where if it's normal, you think about thalassemia, and if it's high, you think about iron deficiency anemia. Differentials in adults, you see neutrophils as the predominant population, then lymphocytes, then monocytes, then eosinophils and basophils. Then the three part is neutrophils, lymphocytes, and mixed cells. It doesn't mean that three part is inferior to five part. It's important how many samples the lab is running and how good the quality control is. Sometimes for a beginner, a three part is more than enough. And if something is abnormal, you can always go and check the smear. Platelet indices are important because we see individuals from West Bengal, Bihar, and all. Sometimes they might be having large platelets. So the machine will not count. They would leave, ignore, and we would get a count of maybe 80,000, 90,000. But patients, that individuals might be absolutely fine without bleeding, and smear will show you adequate platelets, but they would be large. So that's why it's important. Platelet distribution width is something similar to red cell distribution width. So the distribution width will tell you how the cells differ in size. So it is the numerical counterpart of anisocytosis. So one cell is large, one cell is small. So that's the importance of distribution width. That especially in patients with myelodysplasia, you might see markedly abnormal distribution width. In or nutrition abnormalities, we see the RDW is more in anemia. So the most essential part when we interpret these tests are the quality control. So one is we'll have to see the patient clinically, and sometimes the patients might be pale, but the hemoglobin would be 12 grams. So it might be a sample mix-up, lab error. So you'll have to clerical error is possible. So you correlate your history examination findings with that of the laboratory findings. And again, in the lab, the values have to be quality control with internal quality control run within the lab periodically, and also the external quality assessment where the lab participates in programs conducted by the tertiary care referral centers, the teaching institutes, where they will say whether whatever tests we are running is properly giving the reports results or not. So when you observe the CBZ, you see how many lineages are affected. If it's just one lineage, anemia, leukopenia, thrombocytopenia, or bicytopenia or pancytopenia. MCV, if it's low, there are some causes. When it's high, there are some causes. Retic count is a surrogate for bone marrow healthiness, especially when there is anemia. When hemoglobin drops down, you expect the retic to be high. If that is happening, marrow is compensating, it's increasing for the need, but it's increasing the production for the need. But when it's low or inappropriately low, so there's something wrong within the marrow. It could be a deficiency of the nutrients, or it could be a pathology within the marrow. The differential count is important. That's the order what I described in the previous slide: polymorphs, lymphocytes, monocytes, eosinophils, and basophils. You have to be careful whenever you get this monocytosis. Those could be blasts, especially in the setting of cytopenia, or eosinophilia is usually uh, reactive. It could be drug induced Rarely it could be a malignancy associated. Giant platelets we have discussed. So reticulocyte count is the surrogate for bone marrow erythropoiesis, a marker, and normal is 0.5 to 2% when the hemoglobin is normal. That is 12 to 15 in females, 13 to 15 in males, and above maybe 11 to 15 in pregnancy. And when the retic count is low, you say it's inappropriately low, and it's high, it's appropriate. So the simplest way to calculate in the clinic is just multiply the red cells, whatever is being provided by the lab without any correction with that of the retic percentage, that's the uncorrected retic, and you get an absolute value. For example, if the patient has got 1% retic and the RBC count is 5 million, so it will be 50,000 per cubic millimeter, so something like that. So if it's less than that, you term it as inappropriate response. So there is something wrong in the marrow. Either the fuel is not there, like B12, iron, folate, or the marrow is at fault. The factory is in a pathological state. It could be fibrosis, infiltration, dysplasia, or aplastic anemia. When it's more than a lakh per cubic microliter or cubic millimeter, if the response is appropriate, and bone marrow will just show you erythroid hyperplasia, and nothing more will be there on the bone marrow examination. So the peripheral smear, we have discussed the crucial part of the evaluation of anemia. To find the etiology, you will have to list the differentials in the order of priority or the important findings so that the pathologist will know what to see for the smear. On the smear, you look for cell size, the hemoglobinization, whether the cells are properly hemoglobinized, the pink issue is there or not. A cell size is for, you have to compare it with a lymphocyte. If it's less, you say microcytic. If it's more, you say it's a macrocytic. If it's of that size, you say it's a normocytic. A distribution is again for severe anemia, low hemoglobin, they have to be sparsely populated, and polycythemia, they would be densely populated. The second point, polychromasia fragmentation cystocytes, those are for hemolysis. You know there is some destruction is happening to the red cells due to an intrinsic or an extrinsic pathology. Atypical cells could be blasts or malignancy. Dysplasia, you would see in myelodysplasia. Neutrophil lobations may not be proper, or it will be hypogranulated. Autoagglutination is for the stacking of the is the clumping of red cells upon each other due to an immune pathology, commonly seen in autoimmune hemolytic anemia. Rouleau formation is stacking of red cells upon each other like stacks of coins. So that's commonly seen in paraproteinemias or any scenario where there is chronic inflammation and hypergammaglobulinemia. The last two features, teardrop cells and leukoerythroblastic blood picture, go toward together, hand in hand, and that's commonly seen in myelophthisic anemias, bone marrow fibrosis infiltration, where there is a myelophthisic process going on in the marrow. It insults the marrow, and the precursor cells are thrown out of the marrow prior to maturation. So on approaching anemia, this is the simple algorithm. So when hemoglobin is low, those are the values you have to remember: 13 to 11 in males, females, pregnancy, respectively. When it's low, you ask for a retic. You see whether retic is normal or raised or low. Normal or low, then you need the indices help. So if it's low, you have to consider iron deficiency, thalassemia, inflammation, and sideroblastic anemia. If it's macrocytic, you've got B12 folate deficiency, you've got myelodysplasia, you've got hypothyroidism, liver disease, rarely aplastic anemia. Rest all would fall into normocytic. So inflammation, chronic renal failure, or other infiltrative pathology here. The symptoms of anemia, well known. The patient feels weak or tired all the time, could not do his activities of daily living or work. There's dyspnea on exertion initially and then at rest. There's increased susceptibility to infections, and Previous would be cold and pallor might be there, and pica is one feature in the pediatric age group, and even sometimes in the adults also. So those are the differentials for microcytic anemia. Iron deficiency, think about see the RDW when MCV is less than 80, and iron deficiency, you should suspect when the RDW is raised, and always do the ferritin on pre-transfusion sample. Thalassemia, RDW would be normal, but MCV would be low. Again, pre-transfusion sample is important for doing a hemoglobin electrophoresis. Anemia of chronic disease, it's important to know the clinical history. Patient might be having renal failure or an inflammatory scenario like Sjogren's syndrome, SLE, rheumatoid arthritis, or a mixture or a connective tissue disorder. So that is important. Or last is a sideroblastic anemia, extremely rare, but you might get history from childhood transfusions. This is one scenario in microcytic anemia where you need a bone marrow examination. For other things, you may not need often. Families is important in sideroblastic anemia. And so now we'll confine more to iron deficiency anemia. So it's on the OPD practice we commonly see, and most often we treat them with oral iron. So that's the standard treatment given whenever we encounter iron deficiency anemia. One is to supplement the iron to replenish, to bring back the hemoglobin to normal, and then to replenish the stores. Also, parallelly, you have to find out what's the reason for iron deficiency anemia. It's very important because, especially iron deficiency in more than 40 years of age, you'll have to think of GI malignancies or other malignancies. So, simple finding can give you a clue towards why some underlying serious pathology might be there. And this is even in the IV iron is mainly where the patient has got some GI pathology where the oral iron is not observed, or the patient has got a malabsorption, or there is inflammation which hampers absorption, or the patient has got some intolerance. You can remember those three broad categories: GI pathology, inflammation, and intolerance. So those are the scenarios where you would consider IV iron. And even in patients for elective surgery, now they say 3 to 4 weeks prior, if you find an anemia, you try to correct it, so that the outcomes of surgery would improve. So that becomes a part of the patient blood management. So, and they say if oral iron is not well absorbed or tolerated, then you consider IV iron inflammation. And where they say there's an accelerated response, but it's only a grade 2B recommendation. It's not always the scenario, or it doesn't mean that IV is better than oral. Wherever there is no inflammation, oral is as good, and it can give a good response there. Only if there's intolerance, GI pathology, then you consider um, or inflammation, you consider IV iron. And IM, olden days, we use people used to give IM iron, but nowadays it's not recommended anymore due to the complications, the skin's pigmentation, and severe pain which could be associated. So iron therapy, oral and parenteral. Choice is oral in most scenarios, except for those three scenarios wherever I told that's the parenteral. I am an IV, but IV is almost universal now. Hardly people use IM as it's outdated. And parenteral iron, these are the three scenarios you have to remember, where if there is gastrointestinal pathology like an inflammatory bowel disorder, or post-surgery, you have done a gastrectomy and intestines have been removed for an ischemia or ischemic bowel disease, or sometimes an IBD, or post-trauma, then you'll have to consider that. Some patients may not tolerate iron. After iron, they have intractable vomiting or persistent diarrhea or constipation, abdomen pain. So those are the scenarios. Sometimes you might avoid oral iron. Inflammation, the problem is the iron, whatever is trapped within the macrophages, are not available. They are not released easily into the available circulatory pool. So that's why they get trapped in the macrophage activate the system, and it's not available. So that's why in the scenarios like renal failure or chronic inflammation, the oral iron may not work well. So we need to give some IV formulation. If you see the evolution of IV iron, it's so fascinating. Initially, the earlier molecules had the carbohydrate shell, whatever was used to be large and incorporating the iron. So larger the shell, there's a higher chance of immunogenicity and reactions. And now with gradual evaluation, you can see the carbohydrate shell has come down in size. So earlier, 1947, ferric saccharide was there, then iron dextran, high molecular weight. Then after 40 years, we got iron dextran, low molecular weight, and then came ferric gluconate in 99, and then by 2000 iron sucrose was available, and this was widely used, especially in the AN patients, antenatal care. And now we have got these newer formulations: ferromoxitol, isomaltoside, and carboxy maltose. These three are widely, and in our setup it's mostly carbox after iron sucrose, it's carboxy maltose, and isomaltosate are widely used. So the ferric ions, the oxyhydrate, or the polynuclear core has the carbohydrate shell around, which is for stabilization, and the shell size varies on these agents. So that decides the immunogenicity and strength of stabilization. So whatever free iron is available outside the shell, that can cause reactions. So the free iron not incorporated within the shell can lead on to those reactions there. So that's why in iron sucrose, the chances of reaction are slightly more in comparison to carboxy maltose, because free iron might be more. So you cannot the only 200 milligrams of elemental iron can be incorporated within that shell. So that is one reason where it is given in multiple doses. Beyond that, it cannot incorporate within the shell. So another important thing is the deficit calculation. Whenever IV ion is going to be administered, that's the famous Gazzoni's equation. So how to calculate it? Total body iron deficit is calculated by this formula. You have to should know the weight of the patient. 15 minus the actual hemoglobin of the patient has to be multiplied with the body weight of the patient, and 2.4 times. To that, you have to add the iron stores depending on whether the patient is lactating or pregnancy. It would be around zero point 0.5 grams or 500 milligrams or something like that. So roughly, if severe anemias would be around 1.5 grams or 1500 milligrams would be the usual total deficit iron. So you can remember 15 minus hemoglobin into body weight into 2.4 plus the additional for the stores. So that's the famous Gazzoni's equation. And now the IV iron use has been reused rampantly, or even in the OPD patients get in the daycare, they get and go, just not the hospital setup. And there is an expert consensus guidelines which says about, it's a nice paper which says about the different intravenous iron, the uses, the formulations, administration, and how to manage these reactions. Often people encounter a lot of reactions when iron is infused. This was published last year, and I'll just quickly go through those salient features, whatever has been described there. So we, in our setup, we commonly use sucrose, carboxy maltose, and isomaltoside. So there are some formulations which can be given as a single uh, the total dose of iron can be given as a single dose TDI. In some have to be given over multiple doses as an iron sucrose, whereas carboxy maltose or isomaltosate can be given as the total dose iron can be given in a single dose. So they say optimal formulations for the entire replacement would be ferromoxitol, low molecular weight, 9-dextran, or isomaltoside. Suboptimal, they say it's the ferromoxitol generic form, FCM, sucrose, and an iron gluconate. Uh, but we see FCM is as good as iron isomaltoside. So we have got those two in our set. And it's also said that the ferromoxitol as a total duration has to be given over half an hour. That is important. Most of the iron infusions are given completed in 30 minutes. 20 minutes to 30 minutes is what is important. And in pregnancy, the first trimester, they say it's better to avoid IV. The oxidant damage is proposed there. And fetal monitoring is not routinely recommended whenever IV iron is being given. And they also say you monitoring for 30 minutes post IV is not indicated. There is no enough data to say, and we did, usually no complications post infusion is seen. And pre-medications are generally not advised, and only in patients who are prone for these hypersensitive reactions in the past, especially with some antibiotic or something, then there is, you can consider pre-medication. Otherwise, generally it's not recommended. And they say allow 30 minutes between giving iron and other medications, especially to those drugs which can cause some hypersensitivity reaction. And when there is a reaction, re-challenge with the same IV formulation may be attempted following an infusion reaction later also. And other one important treatment emergent problem is phosphorus can go down. So phosphorus monitoring follow IV administration should be guided by clinical symptoms, especially if when the patient has got fatigue, myalgia, and proximal muscle weakness for all formulations, because especially in all formulations except FCM, because FCM is more prone to cause that, and you'll have to consider monitoring phosphorus after giving FCM. So, but important takeaway point for today is that vast majority of the infusion reactions, once we administer IVIN, are labeled as serious adverse effects in most of the settings. The moment the patient has chills, tachycardia, or some breathlessness, it's labeled as a severe adverse event. But actually, they are not IG-mediated hypersensitivity reactions, but they are called as CARPA, that is complement activation related pseudoallergy. So it's complement activation related pseudoallergy, and it's a self-limiting reaction to the labile-free ion. So go back to the slide. You have seen that the free ion might be available outside the core, so that can cause all these reactions. So that activates the complement system, and that can cause a pseudoallergic like reaction, which will be seen in the subsequent slides. So that is self-limiting and does not need any treatment at all. In contrary to the serious reactions with hypersensitive reactions like type 1 anaphylaxis or something, they are not IG mediated. So need not worry much to all the reactions what we see commonly in the OPD or the or in the daycare practice. So you can just, this is a simple picture which gives you a clue. On the top, you have got the, first we'll discuss the allergic IG mediated hypersensitivity. So it'll be easy for you to understand. We know this is a type 1 hypersensitivity reaction. So pre-sensitization is required. So mast cell, maybe on the first exposure, the allergen might sensitize the mast cells. So the mast cells will have some, it will be sensitized. So IgE can bind on to these FC epsilon R receptor, and they become sensitized mast cells once the allergen is exposed. Subsequently, when the allergen is exposed for the second time, these already sensitized mast cells, on seeing the allergen again, can form a complex and that degranulates the mast cells. So all these mediators are released that can cause severe tachycardia and hypotension. The patient might have a vascular collapse. So that is the basis for anaphylaxis. So initial sensitization of mast cell, re-exposure, degranulation, vascular collapse. So that's how you have to remember. But in iron, the labile iron, what does it do? It does not sensitize the in such a does not sensitize in an IgE mediated fashion. So this is non-IgE. So the free iron, it's activates the complement cascade. So the complement cascade products will just go and stimulate the mast cells, which will degranulate for briefly for a transient period, and then it settles down on itself without much intervention. So this is CARPA, complement activated related pseudoallergy. So this is the common reaction what we see with IV iron. So unless the patient has a hypotension or a severe bronchospasm causing hypoxemia, need not worry about the fever and chills what we get sometimes with IV iron. So clinically, what anaphylaxis would produce is hypotension, swollen oral buccal mucosa or lips that is seen as angioedema. Sometimes patient might have stridor due to laryngeal mucosal edema. A generalized urticaria might be there, and stridor, bronchospasm. You have to auscultate, to examine the oral cavity, and also abdomen pain and vomiting might be there because of GI disturbance due to those bases, histamine, other mast cell mediators. Whereas in CARPA, you would see pruritus, not a generalized erythema or flushing or urticaria, just an isolated urticaria at some places. Flushing might be there, chest tightness, but no hypoxemia, no wheeze, and joint pain is very classical of this. Patients might complain of back pain or knee joint pain after, and need not worry. Just reassure the patient. You can stop the infusion for some time. You can give some saline. No need for first generation antihistamines. Only second generation antihistamines are advised for CARPA, because first generation antihistamines can convert it into a serious reaction. So that's why phenylephrine is avoided. It's better to give some loratadine or cetirizine for CARPA. There, other most often it would not need anything. Just reassure the patient, monitor vitals, stop the infusion, give some fluids, reassure the patient, and it'll settle. Then you can just finish off the infusion. And so whenever you get a reaction, assess the risk of the reaction, see whether the patient is prone for high risk. Examples would be an underlying severe asthma or an underlying eczema or atopic dermatitis, mastocytosis on treatment, multiple drug allergies in the past for sulfonamides, penicillins, and prior reactions to any IV antibiotics or IVIN. So those are the high risk individuals. Those are the scenarios where you would pre-medicate the patient. Otherwise, you need not pre-medicate. And those scenarios, you start at a slow infusion rate. Slower infusion rates have associated with lower infusion reactions. But in general, 20 minutes is what is recommended for most of the infusions. But only in these special scenario, you have to give it slowly and observe for the first 5 to 10 minutes. And immediate infusion reactions occur in the first minute. So the longer the time the patient is fine, so lesser the chances of reaction. So within the first 5 minutes, you often see these reactions. After that, it's unlikely. And in case if you encounter acute signs or symptoms during the reaction, first is stop infusion. The nurse has to notify the physician. If it's not, upon completion of the infusion, you can say the patient that after an infusion, the next day or the same day, the patient might develop flu-like symptoms. Some arthralgias, myalgias can happen and need not worry, can just take some NSAIDs or paracetamol. So, and most of the times it would settle. And only if it's persistent or intractable pain, you can seek the hospital care. This is important after an infusions. Flu-like symptoms are common. We'll have to educate the patient and send them home. Otherwise, they'll come back with complaints. And when you get encounter a reaction, so first thing is to stop the infusion and examine the patient vitals like blood pressure, pulse rate, respiratory rate, auscultate, see the oral cavity, see the monitor SpO2, everything, and then you start saline on the same IV line after disconnecting. And it's important to know whether it's a mild, moderate, or a severe reaction. Obviously, severe is anaphylaxis. Patient would have marked tachycardia and hypotension, vascular collapse. Uh, Otherwise, mild hypersensitivity reaction has usually pruritus, flushing, urticaria, chest tightness, back pain, and joint pain. Classically, the CARPA reaction you can remember. Some isolated urticaria or pruritus, chest tightness, but no hypoxemia, back pain, joint pain. Moderate reaction, patient will have some respiratory symptoms in the form of cough or breathlessness, but usually there is no hypoxemia there. Patients might cough, but if you see the monitor will show normal saturation. So you need not worry there. And hypotension, quite unusual there. So in minor reactions, just monitor for 15 minutes, give some saline. Then once the patient is fine, if improved, then you can re-challenge the infusion. For moderate reactions, you monitor for 15 minutes. IV corticosteroid is something advised, and give the second generation antihistamines and not the first generation anti-allergics. You can give famotidine, loratadine, or cetirizine. If hypotension, again, just resuscitate like a usual hypovolemic shock, give some fluids or some nasal cannula, and then maybe you can consider his treatment. What do we do for anaphylaxis there? And re-challenge, you inform the patient, you just reassure in minor reactions and restart in 15 minutes at a slower rate and complete maybe what should be completed within half an hour, maybe completed by an hour. Then if there is no reaction, generally we finish off the iron infusion in less than 30 minutes, because the longer the infusion stays, the higher chance of reactions are there because of free radical formation. And here, if the improvement in symptoms is not, if it's getting worse, obviously we'll have to admit the patient and then monitor, especially to rule out anaphylaxis. Otherwise, if it's not settling with some fluids and steroids, then you can give some ondansetron or second generation antihistamines and continue the fluids until stabilization. So anaphylaxis, you all know well, sudden onset and rapid intensification of symptoms. Patients might lose consciousness. Hypotension can happen where there's a drop of systolic BP of more than 30 from baseline, or the BP goes to less than 90 millimeters of mercury, the systolic. Angioedema, a very nice sign. So the tongue, lips, and all gets swollen, especially laryngospasm can cause stridor. Mm, and two or more organ systems. Cardiovascular can you have to see for hypertension, chest pain, skin, he'll have urticaria, generalized, not localized, and non-airway angioedema can happen. And respiratory, there will be stridor, bronchospasm, GI symptoms in the form of vomiting and abdomen. Those are the clues for anaphylaxis, and treat as moderate hypersensitivity reaction, and you call uh, you do all the things whatever has been done for moderate in the form of stopping the iron, IV fluids, hydrocortisone, and then ondansetron, and second generation antihistamine. Along with that, you can give some adrenaline, zero point 0.3 milligrams IM into the mid thigh, and or subcutaneous 1 in 1,000, and then you can give some beta 2 agonist nebulizer like salbutamol. And you have to report the infusion reactions, very important, with whether mild, moderate, or severe, and how long it when was it when it had its onset, and how it progressed, and what you have done for that, and what is the intervention done, and how did the patient respond, all within how long time, are all important. And previous iron formulations given, you have to document in the chart so that those drugs may not be challenged again, dose and infusion rate. The other thing is the treatment emergent hypophosphatemia, which is quite common with ferric carboxymaltose. So not all formulations, some formulation can host, so it inhibits the FGF23, and that the release increases from the osteocytes, fibroblast growth factor. It does two things. One is it increases phosphate excretion via urine. So the reabsorption of phosphate is inhibited there because of this induced fibroblast growth factor 23 from osteocytes, which is stimulated by IV iron. And it also inhibits the conversion of the vitamin D 25 hydroxy to 125 dihydroxy form. So the active form of vitamin D formation is it hampered there. So if vitamin D is not there, it increases for parathormone, which again leads to decreased reabsorption of phosphate. It further reduces phosphate. So all you have to remember is phosphate excretion is increased, and phosphate levels are brought down by increased parathormone. Active form of vitamin D goes down. So it leads on to secondary hyperparathyroidism, and which worsens hypophosphatemia. So it is hyperphosphaturia and hypophosphatemia. And the urine excretion is increased, and the serum and the plasma it goes down. So that can lead on to bone complications like bone pain, fractures, and all. So this is quite common with some iron formulations and more common with iron. Uh, so what are the risk factors for development of hypophosphatemia or treatment emergent hypophosphatemia? Treatment of FCM, or recurrent or ongoing blood loss, abnormal uterine bleeding, hereditary hemorrhagic telangiectasia, other GI bleeding. The ongoing blood loss can increase the chances of hypophosphatemia. Malabsorptions, so disorders like post-bariatric surgery, inflammatory bowel disease like Crohn's or ulcerative colitis, and small intestinal malabsorption problems like celiac disease. The normal renal function increases the chance of hypophosphatemia, in contrary to chronic kidney disease, because the kidneys function well, so the phosphate is lost. Whereas in CKD, already the excretion of phosphate is hampered, so the iron formulations don't cause much trouble there. So a patient with individual with a normal renal function is more prone to develop this complication in comparison to a patient with CKD. Lower body weight, already low serum phosphate at baseline, and higher serum PTH can all lead on to worsening hypophosphatemia. This is secondary hyperparathyroidism mechanism. So I would stop here. So that's how we manage. So practically, when IV iron is used, uh, most often we use carboxymaltose or isomaltosate, which is now available. A maximum of 1 gram can be given, and a total dose infusion, only in isomaltosate you can cross 1 grams of 20 milligrams per kg, and up to 1.5 grams you can give. Otherwise, 1 gram is the usual cutoff. And you have to remember the newer molecules have a smaller carbohydrate shell and lesser chance of reaction. and deficit is important. You have to calculate to know how much iron to be given. And the reaction part, remember this reaction very important. Most often it's CARPA, it's not anaphylaxis. The patient may not be having hypotension or hypoxia, only pruritus, isolated urticaria, flushing, chestinitis, joint pain. It's not IgE mediated, so it settles on itself, or you can give some fluids there and then re-challenge always. IgE mediated hypersensitivity or anaphylaxis, it can cause various problems like hypotension, angioedema, bronchospasm. There you stop and manage like anaphylaxis. And treatment emergent phosphatemia, especially after IVN, the patient develops proximal muscle weakness or fatigue or severe myalgia, then you have to consider that. So that's about IVAN. So select your patients properly and give overline wherever feasible. If it's not absorbed well, and if the adequate response, what we expect is in severe anemia, a 2 gram raise in the next 3 weeks. So that's how after giving IVIN or oral iron, in the next 3 weeks, 2 grams should go up. If that is not happening, then something is wrong. Either your mainly for oral line, not for IVIN, for oral line. So there, if it's not happening, then you consider probably the absorption is a problem, or the patient is losing blood somewhere else. You have to reevaluate, review the history, ask to see for bleeding sites. Remember GI pathology, inflammation, and intolerance for giving IVIN. So I would stop here and we'd be happy to answer
So thank you very much, sir. Thank you for comprehensive and lucid talk on practical tips in IV and uses part, especially the part what you have covered in terms of the how to manage the hypersensitivity as well as the related to the carpa part and the hypophosphatemia. So just I am having one query pertaining to the hypophosphatemia, especially. Uh, just wanted to understand like what is the doses or probably which reference been used which highlighted that the FCM is more associated with the hypophosphatemia. Like what is the dose actually has been used in those set of patients?
No, this is the that's the consensus guidelines from that paper what has been published, which is widely accepted. It's an expert consensus guidelines where IVI used in formulation admission, but not always. The chances are slightly higher with FCM. So that's what they say. Not all patients develop. So whenever there is proximal muscle weakness or severe myalgia post, and some high risk individuals, you will have to consider monitoring. Monitoring is mainly only if the clinical symptoms are there. But we don't see it commonly, but it's been described. So that's why I've just put that slide.
Okay.
Otherwise, it's not commonly seen.
Okay, right. So thank you. And these
Even
the
recommendation says phosphorus monitoring after IVIN should be guided by clinical symptoms. Only the symptoms are there for all formulations except FCM. But for even in FCM, we don't see much symptoms in our practice. Very rarely. So in those scenarios, we might just consider monitoring phosphorus and then trying to replace it.
answer is it reversible, right? It's like after a
Yeah, yeah.
certain period of time.
Yeah, once we replace, they become better.
Okay.
It's
Thank
unusual
you.
to see that severe hypophosphatemia for a long time causing fractures and all, but cases have been reported, but not very common. Extremely rare.
So thank you, man. Thanks a lot, sir, for your wonderful talk. So probably, sir, if possible, like we can connect over, again for probably after a few, probably few days or months on the second session, especially to have the more elaborated talk on this part, especially.
Sure.
So once again, sir, thanks a lot, and have a wonderful evening. Thank you, sir.
Thank you all.